Good evening, everybody. And today we have got two new people. Danya is old, but still she is going to be there with us. And Dr. Neena Chitnis is going to join us as a rheumatologist expert panel today. And over from all the panel of experts and from my side, we welcome you, Neena, over here. And thank you so much for joining us. We have Dr. Bhavin sir as a radiologist expert. We have got Professor Athol Wells as super expert and Murli Mohan sir, Rajan sir, and Prabhu Desai sir as a pulmonologist. We have five cases, three from my side, one from Rajan sir, and one from Murli Mohan sir, and we will start without delay. So, when we are talking about drug-induced toxicity, most of the times the oncologist drugs will top the list, but there are so many new biologicals in the block, so we don't know which is what and what is causing this. So, I have a patient who has got a long history. She is a cancer survivor. She is 57 years old lady from Palakkad, homemaker, type 2 diabetes, CA breast. She was diagnosed as a CA breast in 2010. She received adjuvant chemotherapy with paclitaxel in 2010, followed by recurrence on the left side, and 2019 she had radiotherapy of 15 cycles in 2019. She also received that time docetaxel 6 cycles in 2021. Now, why I'm telling all these things is because all docetaxel also can cause the problem. And she presented to me somewhere in June 2025. When she came to me, she was referred for dyspnea on existence, MMRC grade 3, dry cough, and generalized tiredness. There was loss of weight of 10 kilogram in last 3 months. And on examination, she was stable, 99 saturation with the normal BP, bilateral air entry present, no added sounds. And her vitals, other than vitals, this were the blood investigation. I did not send CTD workup for this particular lady. She was looking, I mean, very much sick. Even though her saturation and vitals were stable, I felt that she requires admission. So I actually admitted her and I did a CT scan. Before going to CT scan, this is the two investigations done 2 months apart. I think this is the follow-up investigation which I did. Uh, at the time of admission, her FVC was 73%, FEV1 was 80%, ratio was around 100, DLCO was 46%, and KCO was 67%. And she walked only for 300 meters, but no much desaturation. With that background, I think I will give Bhavin sir the screen.
Sorry, it's been a while. I'm a little rusty, so I need to figure this.
This is a Miss S multiple CT scan, na, sir?
No, I meant it was a joke. Sorry.
Yeah,
Sometimes
okay.
jokes fall so flat that, anyway. Can you see can you see Osiris? You
Yes,
can
sir.
see, yeah. Okay, so Asmita sent me some 10 scans starting from 2019, but we realized we just needed these two. So we have the last but one, which is from November 24. And there's this little nodule in which is more extrapleural, probably a neuroma. It was always there. And there's a subtle reticular opacities, which, according to the new terminology, should be called radiotherapy-induced lung changes. So that's what it is. But these are just post-RT changes. And this is a very classic appearance. So then we have 30th June 2025, which is here. And you've got all these ill-defined areas of consolidation, air bronchograms, there's subpleural and peribronchovascular pattern. So now we have an alveolar filling pattern as part of the new terminology. And we would, it's interesting because Asmita has already led us down a red herring path by saying, oh, I think this is drug induced. And she wants us to think of
Mhm.
drug induced organizing pneumonia pattern, etc., which is all very nice. But I think what we do need to do is look at always the soft tissue windows when you're doing this. And when you're looking at this, especially in the left lower lobe, you see these bubble lucencies. And organizing pneumonia per se rarely does bubble lucencies as you see here. So you see the air bronchiolograms, you see these bubble lucencies, and bubble lucencies means either infarction, lipoid pneumonia, invasive mucinous adenocarcinoma, etc. So here we're going straight away from a drug-induced organizing pneumonia to something that would be likely malignant. And what is the proof that there is malignancy? Look at the liver. It's studded with lesions and there's nodularity. And so this patient has got spread into the liver. And so now if you look at the bones here, she's always had metastatic disease in the bones, but the lesions seem to have increased. So I don't know whether this is a new malignancy in the lungs or whether she has just metastatic CA breast with liver, lung, and skeletal involvement. So
So there
that,
was a PET CT done somewhere in April or something,
I
sir.
just deleted all of them because
No, no,
I
no, no,
didn't
no, no.
realize that. Yeah,
I'm
yeah,
just
yeah.
telling. So what happened is those were liver and bone mets were already there. She's aware that
Correct.
she was metastatic
Correct. So
malignancy.
then the lung is also malignancy. It is not drug induced as far
Oh,
as I'm concerned. And I would really want to rule that out. Yes, it's possible that this is a drug induced disease. But whenever I see bubble lucencies like these, you don't see them that commonly in an organizing pneumonia. And so when you see this here is where I'm a little concerned that it could be something more than that. So you just have to figure that out. I mean, if
yes,
she
sir.
improves on her own by withdrawal of the drug and all of that, it's fine. But the pattern's a little off. It's just there's too much consolidation. It's too asymmetric. All features that make me worry.
हं. नाही ते सगळं तर ते अॅन्युरिझमच आहे ते. करायला काय म्हणजे ऑप्शनच नाही दिसत आहे मला. कारण तेच उलटं वाढत जाणार आहे. तो कारण हेमाटोमा इन्क्रीज होतोय ना त्याचा. हं.
Lakshmikant, you need to mute yourself.
Yep. Yes, Professor Athol Wells has raised his hand. Maybe.
This
Yeah.
question is not to inform, but to learn. So in a non-TB endemic area, and I'm used to the fact that these drugs are immunosuppressive, we've been ambushed by TB in a non-TB endemic area when there are patterns that are off. And so in a TB endemic area, I would be very interested to hear from Bhavan whether we need to keep TB in mind for what is in the lungs. I think I get that you feel, based on what you see, this is unlikely, but I've been ambushed by unlikely too often with immunosuppression and TB.
This is an unusual pattern for TB, so I would be very surprised if it turns out to be that. But I think it would
I have
work.
an answer for that. I did bronchoscopy. I didn't do biopsy, sir, because I felt maybe I was carried away with my drug-induced diagnosis, and I didn't want to subject her for unnecessary biopsy. I did bronchoscopy on the next day, and I'll share the remaining slides. So TB, we have answered. We are not dealing with TB. Definitely, because I have even cultures negative by now. So TB has been ruled out. However, I did not do biopsy thinking that she should improve. She had dramatic improvement with Solumedrol, which I started, and presently she is on tapering dose of steroids. And I think we had a delay of one MDM. So this is why this case has been discussed little bit delayed. She is on 20 or 10 milligram of steroids. And my question is a patient with prior docetaxel. My doubt was whether it is docetaxel induced or it is everolimus induced or it is RT induced. That is what, to be honest, this particular thing was not in my differential diagnosis, that adenocarcinoma with lipidic pattern. And should we
It,
pursue lung biopsy? That was my another question. And how long I should treat, or should I repeat a CT scan? And I did not send CTD profile. So do I need to send that? Those are the questions. I usually send it for everybody, but for this patient, I was like, maybe I was overtly sure that it is not.
So before everybody else jumps in, just that this is not RT related, that's for sure. And that radiation recall pneumonitis is a different entity. But I think like things should be simpler now because this is an earlier case. Why not just do a chest X-ray or a repeat CT? If the lesions have regressed, the matter is over. That means you're right, it is drug induced with an OP pattern or something. And if the lesions have remained the same or have increased in size, then clearly it's not drug induced, and then you would have to work up for a malignancy. I think so that would become quite clearer because sometimes all you need is tincture of time, right? I mean, you need a follow-up, and we've got enough. It's been almost 2 months now, so you can easily get a follow-up and figure it out.
How old is the scan, Asmita?
30th June.
June.
30th June. Yes, Athol, you were saying something?
Yeah, just one point, and perhaps not so crucial in this case, but in drug-induced disease in general. For clarity of thought, we say one thing, one cause. I've seen enough to know that sometimes drugs are acting together to cause drug-induced disease. And where this is a huge problem is you see an obvious drug, you assume it's that drug, you stop that drug, you don't go to pneumotox, and you don't actually realize that there's more than one candidate, and you don't realize that even if your primary drug is acting, another drug is contributing. Now, in this case, you've stopped doing therapies that might cause trouble, so it really doesn't apply, I think. But it's a note of caution, that's all.
Okay, if one moment, if I can
What is
just
your...
share my screen, sir. 1 second, 1 second. Can I share my screen for a second?
Sure. While you share your screen, one question, Asmita. What is the oncologist saying? Is
Yeah, so
proving a lung malignancy going to change his management?
no. That's what I'm coming to it. So this was this were the X-rays actually. This is the left side is 28/6 when she was presented, and this is the X-ray on 2nd August when she came for follow-up, Bhavin sir.
Oh yeah. Then you're right. This was drug. This is
It's
all
drug.
gone.
Yeah.
Yeah, okay.
So
Perfect. So then that's great. I mean, it's great for the patient. Just whatever.
One
Yeah,
more cause for a bubble sign. Bhavin?
One more cause for the bubble sign. I can believe that.
yeah.
No.
So now we don't need a biopsy, but do we need a CT scan, sir?
Nah. You
No,
got
okay.
X-rays cleared up. You don't need it.
Okay. I think we'll move on to second case then. This is anything else to be added, sir? Am I right? How long to be treated? Like drug induced. Now X-ray is also improved. How long you treat, sir? Like, shall I just taper it off and finish in
Yeah,
three?
I think majority of the lung part is recovered.
Hmm.
So we can actually reduce steroids and
Okay.
observe.
individual, no? Tolerability, response, and how much she can, how long she's ready to take steroids and what problems they're creating for her or not creating.
They decided to discontinue the treatment that treatment which
Okay.
uh they have decided for that. So
Fair enough. But steroids, I think I would taper fairly rapidly, given the fact that she's already got mets in the bones.
Yeah.
And yeah,
okay,
so
ठीक है. I think that's it. And is your PG there, sir? Muliman, sir?
I am hoping she's there. Uh,
If
Are
she's
you there?
taking, if she's taking time to log on, I can start my case. I have
yeah,
no.
why don't you start? I'll
No,
call
no.
her.
I have
I am
cases.
here, sir.
Yeah, okay. Then
You're
I'll
here.
take your
Okay,
case because
please.
the problem is Danya wanted to go by 5:45. So let
She's
me
here
share.
apparently. So
Yeah, we will start sir's case. So yeah, all yours. Please introduce and go ahead.
Yeah. Good evening, everyone. And here we are presenting a 36-year-old male who presented with the complaints of right-sided chest pain and back pain for the past 10 days and dyspnea on exertion for 10 days, which is more on lying to the right. And on further history, we found he is never smoker and he's working in a cement factory. He also had a past history of recurrent pneumothorax twice in the year 2021, for which initially he was treated with ICD, then he has undergone pleurodesis, and current pulmonary function tests are normal. And on examination, there is no obvious significant finding with no skin lesions. CT chest, we have forwarded, ma'am.
Yeah, 1 second. Yeah.
Okay. So you can see this, right?
Yep.
Yeah, so I think I have one lung inspiratory series which shows the pneumothorax. It also shows a bunch of these thin-walled cysts here. They're most of them the same size. Some of them are a little larger in the middle lobe. This one's a little large as well. And then there is this subsegmental atelectasis in the lower lobe because of the pneumothorax. And then in the left lung, we can see a few cysts here. This one's a little ovoid, little paramediastinal, and then we have all these other smaller thin cysts. This one is perivascular. And the intervening lung is typically normal. You can see the burden of cysts here, but doesn't show up very well on these MINIPs. And we do see evidence of talc pleurodesis with these bright areas in the pleura. So that's fine. So basically, cysts with intervening normal lung really don't have too many differentials. It's PLCH, but the patient is not a smoker. LAM, but the patient is a man. So unless he has tuberous sclerosis, that doesn't work. BHD, which could be possible. We do have one paramediastinal cyst, but this is not really the typical appearance. LIP, there's no other interstitial lung disease. Cystic metastatic disease, this isn't. So basically, I mean, I don't have a clear answer, but the closest by exclusion and maybe looking at this ovoid cyst would be Berthold-Dubé or the new definition, which is what folliculin deficient interstitial
Follicular
lung.
deficiency. Yeah.
My challenge, of course, with these new terminologies is that I never thought BHD was an interstitial lung disease. I always thought it is a category called cystic lung disease. And I thought maybe you can share some light here because now they've been all lumped together as interstitial lung diseases, which I thought they weren't. So, maybe everybody, those who write guidelines are wiser anyway, but nevertheless.
Marvin, I think it's a very simple explanation. A whole lot of things are in ILD, and you have to ask where would they be. Now, the level of excitement in asthma and COPD is such that if you added these disorders, the excitement would rise to dangerous levels. So it's correct that they remain within ILD.
Okay.
I have one other quick comment because I raised this in cystic lung disease meetings. If it looks like BHD, that's predictive. To what extent, if it doesn't look so much like BHD, does that exclude it? And nobody can give me a clear answer on that. And that is an important question. You get a bit of umming and ahhing and a vague sense that if it doesn't look like BHD, then it won't be. But when you push a little on that, I don't think it's well supported. So you may, I mean, obviously, from what you say, it's not typical of BHD, but actually, it could easily be.
Yes, so it is the first diagnosis because nothing else fits, and we do have, and it doesn't go against BHD. We do have a few ovoid cysts. There is one paramediastinal cyst, so I think that fits in. I didn't look at the kidneys, but let me just do that very quickly. There's no other tumor. There's nothing else. No.
Yeah. I'll share the remaining slides and maybe
So
1 second.
just one addition, he actually had skin lesions. He had a few skin tags over the neck. And when I was examining them, he said, look, these have been there all for many, many years, which actually
Oh,
adds to the
okay. Yeah, go ahead.
so
So
Asha.
on further, yes, sir. So on further workup, he underwent diagnostic thoracoscopy, on which he had right lower lobe bulectomy with parietal pleurectomy, and the biopsy slides I have shared.
So when he came in first, because it didn't look typically like a BHD, we decided to, I mean, he needed this thing done anyway. I sent him to our surgeon who did the surgery, including a tent pleurectomy. He had large bullae, so he did a bullectomy, and the middle lobe was pretty much gone, so he decided to do a middle lobe resection and sent off the specimens for biopsy. And this was what the biopsy histopathology result was. Dr. Ritu, you want to take that? Did you manage to see the slides?
Yes, Dr. Murli, I was able to see the slides, but I'm not able to share if the slides can be
Dr.
shared.
Asmita, you have it?
No, actually, I have presentation. She didn't put the slides, otherwise I would. हाँ, I told that she has to add histopathology slide. मेरे पास नहीं है. I'm sorry. So
Okay. How do I'll try if I can share from my screen.
I will stop sharing. Please share if you
So
can.
okay. It's a nice biopsy which has been. I won't be able to. Could you share it, Dr. Asmita, please?
If you have got from your side, you can share. Otherwise, you send me the PPT. I will show the slides. Meanwhile, we can see the genetic report. You just send me the slides, ma'am. I will share. If you have any
I'll
images,
just mail it to you.
yeah, just
I'll just
mail it.
mail you the same.
And Dhanya, you can
Right.
interpret the report for us meanwhile.
Dr. Asmita, can I share my slide? I've got the
Images? Yeah, yeah. Please go ahead. Please go ahead, sir.
Then. So,
Can you see them now?
yes, yeah, but if we could have the full screen, please, sir.
Yeah.
So we are seeing two slides in this, two sections here. The section on the left is showing the emphysema, which is the enlargement of the air spaces. The interstitium is relatively normal on the section on the left. And the section on the right is showing the interstitial infiltrate, the interstitial widening, along with the air trapping which can be seen. So this is the interstitial component involvement as Dr. Bhavan just discussed. So we are having definitely in this case an interstitial involvement also. Then in this section here, there is hemorrhage which is occurring in the adjacent areas. So you have the interstitium which is normal, but the alveolars are filled, the alveoli are filled with the hemorrhagic fluid. And that is all I can comment on this. So the next slide. The next slide here is showing a typical bulla. So it is a large cystic space. The small arrow, which you can appreciate, the thin arrow, is showing the lining of the bulla, and this is lined by a single layer of flattened cuboidal epithelium, and the big chunk in the center with the bigger arrow here is actually the infiltrate which is accumulated inside the bulla. So it is just not air filled. There is an inflammatory infiltrate which has accumulated within the bulla space. And if you see the next slide, it is on higher power. On higher power here, there are this inflammatory collection within the bullous space is showing not only neutrophils, it is to me showing also number of eosinophils and lymphocytes. So the eosinophils, then we see in this kind of a situation is um, uh, there because of the contact with air. And in the history, this patient has had pneumothorax also. So from here, I take it to the next slide. And in this next slide, what is interesting here is that there are a large number of cholesterol granulomas. So the light pink ones are some smooth muscle bundles which are admixed. And the dark pink, which is there, we'll see it in the next section, which is a higher power. These are all the cholesterol granulomas which have been formed. There are some giant cells which can be appreciated. So we are dealing with not only a interstitial pneumonitis. So here it is. This is the typical cholesterol granulomas which can be appreciated. And these are linear cholesterol crystals. So we've read about cholesterol crystals, they're normally square with a wedge-shaped cut. But in a biopsy section, when a cholesterol granuloma is seen, this is exactly how it looks. They are the linear empty spaces where the cholesterol is accumulated. And the dark pink is the granulomatous reaction around this foreign body. So next slide would we go to? This is again showing the granulomatous reaction and the giant cells. And I would like to, because of the talc, history of talc pleurodesis, which has been given, like to put this under polarizing microscopy to see whether I have not missed out any silicates along with the cholesterol which has been introduced. No atypical cells here, no eosinophils here, no evidence of a Langerhans cell granulomatosis over here. These are typical foreign body type of giant cells which can be appreciated. Next slide, sir. Okay, so again, the cholesterol granuloma here, and I think that's it. So, so to me, this is a bullous lung disease with a rupture, with an intrabullous accumulation of inflammatory cells comprising of neutrophils and eosinophils, and with a tissue parenchymal reaction of a granulomatous foreign body foreign body type of granulomatous reaction, which is probably secondary to the rupture which has occurred.
Okay, thank you.
So the verbal message I got was that this was emphysema. So we sent off an alpha-1 antitrypsin, though I was very unhappy with that diagnosis. But so anyway, at the same time, we sent off his genetic tests. Dr. Asha, anything else that you've entered?
No,
No,
I
sir.
think this is the last slide, and I think Dhanya, I had sent you the entire report also. So over to you, if you can just throw some light on this report.
Yeah, so this report actually shows a nonsense mutation in the FLCN gene. So nonsense mutation is actually a more severe type of mutation when compared to missense mutations, because in nonsense mutations there is no production of any proteins. So a Berthold-Dubé patient who is having a nonsense FLCN mutation may be more symptomatic when compared to a patient with a missense or frame shift mutation. So that's the only thing I can conclude. Anyway, they have written it as pathogenic. That is because it's a nonsense mutation. So it is deleterious.
Okay. In what aspect deleterious?
So
In the sense that it isn't.
what is the question on this case?
No, so it is more, to highlight the point that Ethel also often makes, that we need to do more genetic tests, and the fact that when you have primary spontaneous pneumothorax, as Bhavin pointed out, typical features with some atypical features, you do have cysts. And so I really wanted us to highlight the importance of looking at cystic lung disease. Really, right now, there's no question except two. One is he's bound to have recurrent pneumothoraces. We've kind of done a tent pleurectomy on the right. He's likely to have a recurrence on the left. Two, he works in a cement industry. They're not very, very closely with it. Should we advise him to quit the cement industry? He actually works in the offices, not in the production area. So will inhaled lung insults aggravate the problem? And three, we were discussing, I think Bhavin was pointing out that the FLCN4, I think, is more common in India, less likely to be associated with the angiomyolipomas, kidney tumors. So how often should we follow this man up with an MRI scan?
No,
So,
I had said it's that skin lesions are less common, but
Okay.
I think the rest of the stuff remains the same. So you would have to put him on surveillance for renal tumors.
So, Murli, we were discussing this with Nishant Gupta last month uh, on BHD, and he actually said that if you're born, if you had a wish list on genetic diseases, he would wish for BHD syndrome. So what he said, it is such a stable cystic lung disease. Pneumothorax occurs, you do the pleurodesis, and you're stable. So to me, this is news on the nonsense and missense mutation being worse. So we actually didn't discuss that, but if there is a genetist who has said that, is there any evidence to back that up, Murli, that we have a worse prognosis because of this mutation?
So, at least in this man, he certainly seems to have much more disease than I usually see with a BHD. He does not have a family history. He's
Right.
got the skin changes that we expected, the skin tags that we expect to see. So, I think he fits in with BHD. But to
For
my
sure.
mind,
Yeah,
he's
for sure he
progressed
has
much
BHD.
faster.
Yeah. No,
He's
no, for sure
progressing
he
much.
has BHD. Yeah.
Yeah.
Yes,
So,
Athol, you had a.
brief comment, a brief question. So, Barvan's take, you don't rule out BHD. We could say typical, it was reinforced in stage by
We
this.
can't hear you, Athol. We can't hear you well.
Can you hear me now?
Yeah,
yes.
Yes.
better, better.
I will shout. What I said is brief, but because of this, it's a little less than brief, a little more than brief. It reinforces Barvan's call on BHD, although it was atypical, and that you don't say that if it isn't typical, it's not BHD. Obviously, but I do see this as a frequent problem. I just wanted to ask again about cholesterol and granulomatous element here.
Not able to understand you, Atul.
Your voice fades and
Dropping and
comes back, comes back, fades. Athol. I don't know why that's happening.
Nor do,
It's not,
do I. Did you hear my previous comments?
no, no.
Really? None of my previous comments?
No, you would just get to the gist of it and it would fade away. So I don't know what was happening.
He is auditing what I say. Don't know what to do about this because I don't think it's a
Now
home.
we can hear you. Now we can hear
became
you. And then suddenly it goes off.
Okay, why don't you start waving at me, Suji?
Yes, we can hear you.
I was just going to say, it's a shame. I had one or two great comments earlier, and I'm sure that actually none of them came through. But what I was going to say is two things very briefly. This does reinforce, don't look at a scan, say it's not classical for BHD, therefore it's not BHD,
Right.
which is what Barvin, I think, was saying. But
Yes.
it is a common error here in cystic lung disease. About the granulomatous cholesterol pneumonitis bit, which answers Barvin's question about why cystic lung disease should be an ILD, but about it, how are we seeing that bit in perspective now?
So could this be a
Exactly.
talc-related phenomenon?
I was just
Cholesterol
thinking
granule?
talc related, but
Yeah.
they should have done biopsy before talc, na, sir?
No, no,
That's
no,
what.
no, no, no. So the talc was done 2, 3, 4 years ago, and then
Oh,
the
I was
biopsy is
thinking,
now.
yeah.
So are these talc granulomas or granulomas related to talc
Oh, that
pieces?
is also foreign body. Yeah.
Actually, for talc granuloma, I would like to do a polarizing microscopy and rule out the silicates. And these are two distinct, they're very distinctly cholesterol granulomas. So very distinct. I mean, and there are large number of cholesterol granulomas and the foreign body granulomatous reaction around them.
So that would be foreign body granulomatous reaction to prior talc pleurodesis, right? Isn't that a
Talc, we so far haven't
But
we haven't
is
documented.
there any
Dr. Ritu,
component of
Dr. Ritu, can I add the lab that looked at it initially did polarizing microscopy and they showed refractile granules. So I think we're fairly sure it's
Okay.
talc-related granulomas. The cholesterol we assumed was because of the pneumothorax, which caused collapse, and then that led to the cholesterol accumulations.
It
But
would.
I think pleura also should show the tal granuloma if it is really there. Similar.
Maybe.
To online and type in BHD and cholesterol granulomas. That's the only thing. I mean, I can see that it might be a quite separate pathway, but I don't know what rare associations there are with BHD.
Okay.
Yeah, but I was looking up what Murli said, and it does seem to say they have worse prognosis, and this is
I think
education.
Danya is
Yeah.
here. I would, before you leave, Danya, if you would like to add upon something on the report which I have sent you, please give your comments and you're free to leave. No problem. Danya?
Tanya
Yeah.
from the genetics
So,
department.
Yeah. Yes,
Oh,
sir.
great. Oh, great.
Yeah.
He's left.
so I think in the previous session, I had actually from the literature, I had already told that there were two different mutations which are commonly reported in Barthog-Dubé, where two of them were associated with lower risk of renal cancer, and one of them was associated with a higher risk of colon cancer. So actually, this mutation doesn't fit into any of those. So this patient should undergo surveillance for renal cancers and also colon cancers, like any other patient with Barthog-Dubé.
Great. That's
And
very
as
thankful. Yeah. Very
yeah,
useful. Yeah.
And which was that mutation once again, that with low risk, Danya?
yeah, that was a C.1285 deletion
Yeah.
C
Yeah, deal.
and
Yeah.
C.1285 duplication C. So
Okay.
only these two, they have a specific phenotype genotype correlation. None others have.
Okay.
Okay.
So my other question about this patient was, he works in the cement industry. Does exposure to any irritant aggravate or accelerate the course of, the damage in BHD?
So to whom is that question?
Not to you, don't worry.
Not to you. You've
Thank
given
you.
us
You
very
can.
useful information. I will
Yeah.
continue to follow him up with
Thank you.
these specific things in mind. But I think I erred on the side of caution, and I said, get out of the industry, because any kind of exposure is not good for you. So, because, I think Dr. Prabhudesai was making this comment. It's about the plural involvement and non-plural involvement, because he's
Yeah,
in the cement industry. Yeah, you wonder whether he's been inhaling cement dust and that's triggering off some granulomas.
Yeah.
Right. Thank you all very much. That was very useful.
Yeah. I think that.
Asmita, one request. It's already 40 minutes.
Yeah,
down.
I'm going on,
Any more questions?
going, sir.
Or
Yeah.
rapid
Thank
fire.
you, Danya. Thank you, Danya, for your input.
Yeah.
And moving on to the third case.
Thank you.
7 minutes per case.
Yes, sir. I will finish.
Yes.
So this is from Tamil Nadu. The patient was from Tamil Nadu and he came to us with multiple CT scans from outside. He is already on oxygen support since the month of February, March, but he stopped by himself. He has received multiple courses of multiple therapy like cyclophosphamide, MMF, pirfenidone, nintedanib, Predmet, everything he tried. He was labeled as SLE, ribosomal protein 2 plus positive. History of hospitalization twice. The last hospitalization CT scan was suggestive of congestive cardiac failure, according to me, but I'm not sure it was admitted. CT was also done outside. He was also admitted outside. When he came to me, he was still dyspneic, grade 3 dyspnea, and knee pain, feverish feeling, loss of weight, clubbing present. Saturation on room air was 92 and BP was stable. This were the investigation done outside, except the ANA2 plus was done from my side. CRP and ESR were okay. 6-minute walk test, he walked only 240 meters. From 92, it became 73. These were the investigation done from my side. And these are the, for Nina, if you think this is significant, he has ANA2 plus cytoplasmic, ANA profile, I believe negative, NXP2 of 19 or 1 plus. Do you think this is significant? And with that, I think I'll stop my sharing my screen also.
Before Nina, rheumatologist comes on, can you just show that serology? You went really super fast. I just
Oh, I was like, nothing is required. I'll just show it again. Yeah. Yeah, please.
Just go back. Yeah, this slide. Okay. So ribosomal protein 2 plus, CCP negative, myositis negative. Okay.
C3, C4, I think it was normal, 13,162.
Sure,
And
sure.
this is our hospital. That was outside hospital. I repeated it. Our is ANA 2 plus cytoplasmic and
Sure.
myositis profile.
Sure.
Okay. Sir, you can share your screen and Nina can give her comments.
Nina?
Yes. So, the ANA blot which was done outside, the ribosomal P is a very non-specific antibody. So even for lupus, one thing, lupus itself doesn't present only as a predominant ILD without anything else. And ribosomal P, even if we have to take it for lupus, it should be present with dsDNA or anti-SM or SSA. So only ribosomal P, I would not give any significance unless some other things of lupus are present.
Okay.
Sure.
Can you show me the myositis panel again?
It was
There was something
NXP2,
positive.
Was negative.
19. NXP2 19, 19.
Okay. So again, NXP2 is not something which is routinely associated with
Sure.
ILD.
Okay.
So that also, if
You
it's
won't
not
take it,
important.
yeah.
Yes,
Yeah.
yes,
Okay.
absolutely.
Thank you.
Isn't NXP2 associated with malignancies, Nina? Or
Yes, sir. Yes, sir. It would be more for myositis to rule out malignancy,
got it,
but it
yeah.
is not routinely associated with ILD, very rarely.
Sure.
Sure, sure.
Okay, so if we quickly go through these, there's December 24, Feb 25, and August 25. We have this correct case, right, Asmita?
Yeah, correct case only, sir.
So if you look at the pattern, if we go from, there is an apicobasal gradient, we see these reticular opacities, there is subpleural sparing in the upper lobes, a little bit of an axial distribution in the upper and mid zones. But in the lower lobes, we have this classic appearance of subpleural sparing, and it's a mixed fibrotic NSIP OP pattern that, we would say is connective tissue disease, ILD. Pretty much that is the pattern that you would get. Now, if you look at the left upper corner and the right lower, that's August 25 to December 24, there is no significant change. But the patient likely had acute exacerbation in February 24 because we have a lot of extra ground glass around these lesions, which has then since regressed. So what here you can see all these areas of ground glass, which represented acute exacerbation, acute inflammation, infection, whatever it was. So and the patient's MPA is dilated, patient has pH, likely, all of that. So basically, mixed fibrotic NSIP OP pattern, no significant change between December 24 and August 25, and acute exacerbation in Feb 25.
Now, sir, GGOs has been cleared, right? You
Yes.
filled? Yeah,
Yes.
okay. But fibrosis is status quo. Okay.
Yes.
Yeah, okay. So I think that because since he was already on antifibrotic, I have continued those. And I think from my side, Mithun has started uh, mm, MMF 500 milligram BD. The questions were with ANA that she has already answered. So antifibrotic, should I continue? And immunosuppression strategy, 4 cycles of cyclophosphamide and other drugs. I think rituximab was also given, but he's not very keen on. He is having financial constraint also. So switch to MMF as a thiopurine or anything. And what will be the prognosis by looking at his CT scan? His age is around 45, 50 only. So those are the questions for the panel. Yeah. Yes,
Yes,
sir.
Athol. Go ahead, Athol.
I'm going to quote the table in Sujit's consensus statement that if you're picking patterns, that immunosuppression might be more likely to be the right answer. OP and OP-NSIP are the patterns. We are not, I think, getting a convincing CTD setting. It's the curse if you've got immune dysregulation in the lungs, you will get a few non-specific autoantibodies at low titers, and we shouldn't be turning that into CTD-ILD. So we haven't got a CTD-ILD to make this more likely to do badly. And I think immunosuppression at this stage is the right approach without an antifibrotic drug at this point.
Oh,
Can I comment?
yes, sir.
See, considering the lupus as a diagnosis with this sort of a lung picture, Okay, and which is there is a very acute presentation of there is an the last scan shows a very aggressive disease, especially in the bases. It's the worth doing a bronchoalveolar lavage on him first to rule out infections which are not missing something, though patient doesn't have fever. Okay, and also is there any possibility of a malignancy developing there, bronchoalveolar cell carcinoma, in view of this sort of phenomenon? Because lupus rarely comes like this unless there's some complication. Lupus like pulmonary hemorrhage or
Yeah.
Yeah,
Okay.
so I think a BAL makes complete sense. You get infection out of the way, you can get the cell differentials, and I think then you could be safe on pulsing and thinking of B cell, T cell depletion, all that. All
yeah.
that can be done after that.
Cell block also can give us a
Yeah.
diagnosis
Sure.
of atypical cells.
Okay.
Yes, Athol?
Just very briefly, I don't rule out CPD declaring itself downstream. And in some of these cases, we see that I would caution against using that low titer antibody as an argument.
Sure.
What
Okay.
was done between November and February, between the worst picture and the improvement? What was the treatment given?
So there was a diagnosis made that it was I think right heart failure, and then patient was started on CPAP, and patient was treated with CPAP and diuretics, and he improved, and then he took a travel this thing leap from there Tamil Nadu to here, and he came here to second opinion. Then I initially didn't start any treatment, continued what he was on, and then repeated a CT scan expecting if it was a cardiac failure it should improve. So that is what my plan was, but I think the lower lobes are not improving, right, Bhavin sir? It is same only, no, all flooded
Nothing
alveolar.
has improved. So what the acute, whatever
Insult.
happened,
Yeah, yeah,
has gone,
yeah.
but the fibrotic component is unchanged between the December 24 and the current scan.
Why
So
not steroids? Because what I am seeing is all GGOs.
no, the GGOs are gone. Now there are no.
Okay. Okay.
So, I
Then
mean, that's a valid thing, that it was fluid in between, which cleared up with CPAP and diuretics.
yeah.
And we are left to the background interstitial lung disease, alveolar filling disease, fibrosis, whatever.
How's the echo?
I think see echo. Let me see if I have put from the outside report or I have not done it yet.
Okay.
Yeah, I'll do that.
There is hardly any facial edema. There's no pleural effusion. So
No,
much amount of cardiac failure.
Lakshmi had put in a comment about pleural effusion and whether he's in fluid overload.
Yeah, so
And
I
he
have convinced him.
he's very
Yeah,
dyspneic. He desaturates like anything on
yeah,
walk.
yeah. My diagnosis was also, but yep. Anyway, moving on to so antifibrotic. Professor Wells is saying we should not give, and immunosuppression should be continued after doing BAL. That is what the consensus opinion is, and the diagnosis is not CTD-ILD, right? Can we
Not
just
this point.
not CTD-ILD? Okay, okay.
So basically, a fibrotic ILD
Mm-hmm.
unclassified for
Yeah.
for
Okay. Unclassifiable and needs further investigation. Okay.
acute exacerbation seems to have resolved.
Yes, sir.
Why it has resolved due to what we are not
Yeah.
sure.
Yeah. So this is last case from my side, and we have Sujit Rajan sir's one more case. So he's a 70 years old driver who presented with type 2 diabetes, systemic hypertension, left PKR. Nothing significant history. Ex-smoker for 40 years, but stopped for 5 years. Exposure to dust because he was construction supervisor. Presented with cough and breathing difficulty for last 7 months, and some allergic history which is not significant. Bilateral basal crepitations, clubbing present. This was ANA profile, and I will be slow here because ANA is negative. RA factor was 20, but only borderline positive. Rest all things were negative. Profile is also negative. This is myositis profile for you, Nina. Any comments? Are you muted? Yeah.
Yeah. So
Yeah.
Me2 alpha is mildly borderline positive, and SAE is again borderline positive. So again, like the previous report, these two, one, so they are borderline positive, they're not strongly positive, and other they are usually don't present as an isolated ILD.
So you think it is not significant, right?
And
Moving
not
on
for
to,
ILD.
okay. 39% FVC, 46% FEV1, ratio of 121. Walked only 240 meters, did not show any desaturation. With that, I will stop sharing my screen and over to you, Bhavin.
So we, yeah, so we can see this scan. It's from last month, and if I go from the top to the bottom, we have some paraseptal emphysema. How many pack years history of smoking?
For 40 years, he smoked, sir. So
Yeah, but how? Forget it. It's fine. So
one packet, I think mostly. So 40
okay,
pack.
so
Yeah.
reticular opacity, subpleural basal predominance, honeycombing in the right base, but not in the left. Traction bronchiectasis. No, you do see honeycombing again here. No ground glass, no nodules, no cystic change. Some paraseptal emphysema, no significant centrilobular emphysema. For all practical purposes, this is a UIP pattern, and if there is no etiology, we would think of IPF. But every smoker, we also look at it from the perspective of, is there a lung nodule? And this on in the right apex is what is worrying, because I've got a kind of a semi-solid, subsolid lesion adjacent to some cystic areas. So I would really worry about a paracystic neoplasm. Now, could it turn out to be just some superadded inflammation? On a single scan, yes, but this is the kind of lesion that merits a follow-up at 3 months. And then if this lesion persists and hasn't gone or increases in size, I would really worry about this being lung cancer. So then you would need a biopsy and stuff like that. So we've got
Oh.
a UIP IPF, and then we have this problem of a focal lesion in the right apex.
Is there also some pleural involvement there, Bhavin, at the apex?
No, it's just okay. You mean with that focal lesion?
No, adjacent to it and more medially.
Um, on the right side, this
Yes,
this
right.
stuff.
Yes,
It's
yes.
just some pleural thickening. It's bilateral.
Okay.
It's
Yes.
actually extrapleural fat that has increased.
Okay.
So yeah,
So you
that's
want me to follow up that right upper lobe at 3 months
absolutely.
and
Oh yeah. That would
okay,
be the one I would really worry about. Yeah.
sure, sir.
And the other question I had for you, sorry, Bhavin, is there any the fissures, do they look a little nodular?
They do, but the thing is, all UIPs, they have that fissural irregularity. Let me show it again. And so we do land up sometimes thinking, could this be sarcoid, if that's what you're hinting at? But it's really because it's subpleural fibrosis, and so subpleural fibrosis occurs even in the subfissural subpleural area.
Yeah.
We need to be a little careful about that, especially when it's a significant peripheral fibrosing ILD. So
Okay. So Lakshmikant has asked whether it is CPFE. We don't say this CPFE, right, sir?
yeah, we don't have enough emphysema to call it CPF. CPFE is an emphysema. It is, I mean, Athol can correct me if I'm wrong, and he has very strong views on this, but CPFE is an emphysema with superadded fibrosis, not the other way around, is
Yeah.
the phenotype. So.
That's right.
So I started him on nintedanib 100 milligram, planning to increase to 150. Anything else I should be doing? Yeah. Yes, sir.
Very briefly, I've used CPFE as a diagnostic cop-out. You've got emphysema and you've got pulmonary fibrosis of some kind, and you should be trying to classify the pulmonary fibrosis. People tend to say CPFE because it's comfortable. They've got a pseudo diagnosis. And this is IPF with emphysema, and calling it CPFE, even if there was enough emphysema, does not help us greatly at that point.
Yep.
Yeah.
Okay.
That's right.
So nothing, na? My treatment is fine. I'll go ahead with that, and I'll follow definitely up that right upper lobe lesion and sharing the final case.
4 minutes. It has 4 minutes.
I think Rajan sir will
Considering
take.
we've been finishing at 6:30, I think we are doing good time, Bhavin.
Yep. Yes, sir. Why?
I respect your need to move fast today.
Yep, sir.
So this
No,
is a
my
link.
trip is cancelled. I'm sorry. I didn't tell you that though.
Oh, okay.
Okay.
Not going it. But yeah.
So this is Mrs. PB, 64-year-old female homemaker. She is obese, body mass index about 31, hypertensive, no exposures, married with 3 children, and has exertional dyspnea for 4 years on kitchen work, stairs, but she rarely does stairs because of her knees. Long conversations, especially animated ones, make her breathless. She has a seasonal cough, no past TB. She had a left TKR done in 2021 and a hysterectomy and a left implant. This was the surgical, no autoimmune symptoms or family history of ILD, and frequent UTIs the last 1 year. Saturation's normal on room air, echo pretty good. Treatment history, someone prescribed her nintedanib in June, which is 2 months ago. She developed hypertension in 2 or 3 days and stopped the nintedanib. These were her bloods. Creat 1.4, A1C 5.5, and we had an ANA by immunofluorescence, Nina, that was speckled, nucleolar. And on the ANA blot, there was AMA M2 antibody positivity. Myositis blot, we had SRP, which was 2 plus, and M2, which was 2 plus. I don't have the panel to show you, unfortunately. The HP panel was negative. C3 was okay. CRP was normal. And so these were her lung functions done 10 months ago and 2 months ago when I saw her. A little before I saw her, actually. I saw her just first time earlier this month. And so her lung function actually got better. She had had she had no old scans, um, and she wasn't desaturating much on the walk. So I don't know what next to do with her actually, and which is why I wanted everyone's view. And this Bhavin will show her scans. And she's managing her life, but she is breathless.
So I think the first time she had a scan was a cardiac CT done in May 25, which shows an interstitial lung disease, but there's no change. I'm going to get out of that. And from the soft tissue perspective, the MPA is about 29 millimeters, but beyond that, there's nothing to shout out. Maybe a gallstone and some mild hepatic steatosis. So I guess she goes into a hospital that believes that all gallstones should be out, and she's a candidate for a fourth or fifth surgery in her life. But apart from that, here are the lungs. So nothing much. So you do have reticular opacities in the non-dependent upper lobes, and she has a single layer of apparent honeycombing. And I'm just using all these hedgy terminologies. And then as we go down, we keep seeing dependent reticular opacities. We don't have prone images. One cyst, not significant. There is this one nodule, but it's calcified. That's also not significant. Sorry. And then as we go a little further down, then we have again what looks like a single layer of honeycombing with reticular opacity, subpleural basal predominance, etc. I'd love to have prone images, but we don't have that. And the thing is, while it fits into a UIP pattern, and you'd say honeycombing, subpleural basal predominance, nothing else. The single layer of honeycombing, kind of like cyst-like, maybe there's some airspace expansion. It's a little, it's not what is a classic UIP IPF. So one of the things is, could this be connective tissue disease with an unusual expression? The second is this the residue of a one-time insult that has caused this? I don't know, but or
Sure.
is it just a very early
Sure.
UIP that's just presented in this particular manner. But it's just that, single layer of honeycomb cysts is always
Sure.
just question. That's about it.
So before the pulmonologists come in, Bhavin, Nina, Balkrishnan had seen her clinically, and Balkrishnan felt there was nothing on connective tissue disease. He said that don't do anything. He looked at the serology. For everyone else, Balkrishnan is a rheumatologist in Mumbai, and he said just watch for autoimmune symptoms. Currently, no active rheumatological treatment. Nina, would you agree with that based on the serology and what you?
Yes, sir. So again, I think your ANA blot showed an AMA positive, right?
Yes, yes.
So AMA again it's not related to ILD and in fact not related to any of our CTDs also. It is for biliary cirrhosis and many times comes just positive in the ANA blots.
Got it.
The myositis profile, I think it was SRP positive, sir, right?
That's right.
SRP positive. So SRP positive is for necrotizing myopathy. They can have ILD, but the predominant feature would be a very progressive myositis rather than an ILD.
Sure.
Very rarely they can have their only case reports of SRP presenting as an isolated ILD, but that too the ILD is generally mild.
Okay.
So if you have no other diagnosis after ruling out everything else, then
Yeah.
as I said, as a rare association, SRP can have an ILD.
Okay.
So
Got it.
if after ruling out everything and the CT picture is fitting into maybe a CTD ILD, then the diagnosis of CTD ILD can be considered. But as I said, this is not a common antibody.
Which is why actually I wanted the rheumatologist's opinion. And now with this single layer of honeycombing, my concern is, and I haven't heard of nintedanib-induced hypertension. So Murli, Prahlad,
So
Athol, have any?
before you all start, right? I mean, I need to draw your attention to a couple of things. One is, I've done a little bit of a thin MIP here on the soft tissue windows, and you can see that there is centrilobular emphysema. So a never smoker, centrilobular emphysema. I don't know clinically whether there's a COPD pattern as well. But this is present, and the reason I bring this up is because what was worrying me with the single layer of cysts is all this. So when you have these widened areas, and I'm trying to show one particular, yeah, you see this pattern here. Looks like, you could have some stalagmites and stalactites kind of hanging from these
Yeah.
cystic areas, right? So that
Right.
that is airspace expansion with fibrosis, which is AEF, which occurs in COPDs. It's most common with smokers, but it is also described with non-smokers. We see it in our wood chula exposures, etc. And so, question is, if you have AEF, then and you have some centrilobular emphysema, what is the actual phenotype that you're dealing with? Is this perhaps an exposure-related ILD some sort? I
Sure.
don't know. I'm just throwing it out. I hadn't noticed this when I did the opinion, Sujit, I must say. But
Sure.
now that I'm looking at it, I can see that. And I think we can all see it. There is emphysema, as I
So her
said,
total, yeah, her total lung capacity is 76%, but she's also obese. So I don't know,
but see,
Athol
that
could,
that
yeah,
explains the single layer of cyst, because when you get AEF as a primary pattern in a patient who has emphysema, it's always a single layer because it's emphysema. AEF is airspace expansion of so the word to understand is traction emphysema. It is an area of emphysema that, because of fibrosis occurring within the emphysema, is pulled apart. And so it's always a single layer. And you don't act, and the differential is honeycombing. So now more and more that I look at it,
yeah,
it's everywhere a single layer, and there is centrilobular emphysema. This is actually this is emphysema with a little bit of extra fibrosis. That's what it looks like.
got it. So I think based on what you're saying now, Athol, no, now Bhavin, I will definitely watch her. I'm not going to jump onto an antifibrotic. and look for history of exposures. But I would love to know what Athol, Prahlad, and Murli have to say.
I'm going to say that before hearing from the rheumatologist, I think you could have deduced that respiratory muscle weakness is likely to be a problem. Why do I say that? Because
Sorry, Athol, your voice suddenly went off again.
okay, you hear me now?
Yes.
So I would have said from the lung data that respiratory muscle weakness was on the table. Because
Right.
this patient, whatever the ILD is, walked 288 meters with no desaturation.
Yes.
So ILD might be causing that amount of dyspnea is very mysterious. There's clearly no vasculopathy on the lung function. Then you add the fact that the FVC was as low as 56%, going up to 68%, despite the fact that you can't enough on the scan to account for that. And I think you come up with a hypothesis that something extrapulmonic may well be driving the dyspnea. Sometimes with respiratory weakness, you just get the stress of working the respiratory muscles, you become dyspneic, but it's not bad enough to drop your oxygen. So I was then very interested to hear the rheumatological interpretation. I think it makes sense that you may well be dealing with respiratory muscle weakness as part of the reason that the dyspnea doesn't make sense, because it sure doesn't once you've got the 6-minute data. It doesn't make sense for ILD dyspnea. I get through all of that without vanishing.
Murli?
To me, first of all, I think there is COPD, whatever the etiology. I think Bhavan shown that very convincingly. The second is she's obese and she's probably deconditioned badly, which may account for a large part of her discomfort when she's doing things. We certainly cannot, in the presence of at least some features suggestive, serological features suggestive of myositis, keep that in mind. So I'd like to follow up on that. But at this point in time, I think I'd be looking for evidence of small airways disease. I'd probably do an IOS in addition to her spirometry, check what her 6-minute walk distance is, see if it continues to get better with treatment of her obstructive airways disease, and definitely hold off on the antifibrotics.
Yeah.
Prahlad?
Yeah, I think I will go back to history and try to find out the exposure, whether
Yeah.
she has any detailed exposure, probably hobbies and other things, probably what she does, where she goes. All those things may help us. And second thing is that what you have pointed out, the flow volume curve, I would like to see how it is. And of course, the impulse oscillometry probably will 100% guide us regarding small airway disease. It's more of a small emphysematous changes with probably small airway involvement, and that's why she has more of some paraseptal emphysema or whatever the cystic lesions which are there. But this is very well documented, Bhavin. See how the seeing the CD will probably help us is this way probably. No? Otherwise, we have missed completely the diagnosis.
Yep.
So Lakshmikant is saying treat the COPD, observe the ILD. But what's my working diagnosis? Athol, what would you put as a working diagnosis here?
I would include likely respiratory muscle weakness because I think the obesity will not give you 56%, might give you 68%. TLC is 76%.
Right.
This, I suspect, an element of respiratory muscle weakness. That makes it multi-compartment. And the moment it's multi-compartment, and then we're being told that there's a CTD flavor to the autoantibody.
Sure.
Like a working diagnosis says a form of CTD with some ILD features. Now, how that fits with the airways, it is multi-compartment if the airways are that. So it would be a working diagnosis made with low confidence of a form of the ILD, and like the others, I wouldn't be launching on antifibrotic therapy. I might attempted to test the respiratory muscles, though.
Sure. Okay, that's good. So CTD ILD, Smita, with low confidence,
Yes,
and we'll look
look
to
for
rule
respiratory
out
muscle.
and to rule out small airway disease. I think
Yep.
an history of exposures. Yeah.
I think
Great.
that's it. And
Thank you.
yeah, one more thing I would like to ask. 5th September is the next MDM, but that happens to be Onam in Kerala. Uh, so
Okay.
either we can do 29th or we can do on 12th.
Why
I'm,
not 5th?
I believe 5th September is like,
It's Onam. There'll always be a
yeah,
festival in India. No?
you are so bad. I will do on Diwali then.
Sujit, the Catholics are worse. They have a feast day every day of some saint or the other.
So you should be considerate.
I
I
think,
am
Asmita,
feeling,
it's better to get offline before we have more
yeah.
conversation.
Okay. Anyway, we will announce the date very soon. But thank you so much for all those who joined, and thank you all my panelists and experts. And Bhavin sir, thank you
Yeah.
so much.
As
Yeah.
as Lakshmi said, Onam is in the morning. 5 o'clock evening is fine.
Oh, he's so bad.
Thank you.
Thank
But
you.
remember, you'll all be bloated with the Onam Sadhya, which is
All
not a
right.
great.
Yeah. I don't mind. Actually, I'm not very fond of
I'm
festivals,
fine.
but
I'm fine with it. Yeah.
Onam is one thing which is I'm not sure whether I'll be in the station also or not, but mostly I will be here only. No problem. So if
Wherever,
I'm here, yeah, I'm here, I will be here.
wherever Bhavan is a festival, in my observation.
Yes. I'm just elated that Bhavin has cancelled his trip because the second ops can go next week to him again.
Don't be so elated. I was away for 2 weeks, London, Dublin, everything was fixed. My God.
Oh God.
Everything
What?
is off. I had a conference in Dublin, and so,
Oh gosh.
but it's just not working out. So,
Oh.
another time. Yeah. But anyway, see you guys
Yeah.
sometime.
Bye, everyone. Thank you.
Thank you.
I before you leave, one last question, Bhavin sir, about that BHD disease. There was a pneumothorax, and inside the air you showed me the cyst. So I was like, most of the times we think that is kind of bulla, na sir. You can't see anything inside the air, na. If
Actually,
it is
inside,
pneumothorax.
no. So if you were to reconstruct, it would be a subpleural cyst which is projecting into the
Okay,
which
okay.
that's the second patient, right?
Yeah, but BHD patient because you showed me a cyst inside the
I
air. So
will, I will I
yeah.
will show it to you. So let me do that here. I'll share my screen.
Yes, sir. Yes.
Okay, so that's the one you're talking about.
Yes, sir.
If I were to, so you see that here? That's the,
That's the yeah peripheral. Yeah. So it is
oh,
attached to pleura. Okay.
let me see this 1 second here. So you see that? That's the line. So it's basically a subpleural cyst projecting into the thing. And sometimes if you actually look at these, if there is there's a small fistula or something, you'll actually see that cyst is showing a gap somewhere. And that is the one that's ruptured. So let's look at this one also. You'll see that also like that. You see this fainter cyst here. That's
Okay.
also a subpleural cyst. So, yeah. So on the axial images, sometimes they look like they are projecting, but if you look at sagittal coronal, then it's usually not difficult.
Okay. Okay. Because I was like, is it bulla? And then they told
No.
emphysema and all. Yeah.
Yeah.
Okay.
Cysts.
Okay. Thank you. Thank you.
All right. Take care. Bye bye, everybody.
Bye. Thank
Take
you.
care.
Bye.
Bye.